Welcome back from lunch. Welcome to those who've just arrived. My name is Neil Hanley. I'm Pro-Vice-Chancellor, Head of the College of Medicine and Health here at the University of Birmingham, and it is always a real pleasure to welcome people onto campus. We hope everyone has a lot of fun. It's lovely to host the Association of Physicians here in Birmingham. And actually, do you know what, before I start, I'm really proud that we've got Liz as the president as well. So congratulations to you, Liz, on that. It's tremendous. So good. So this is the Griffin Lecture. So the Griffin Lecture is in honour of Professor Sir George Griffin, outstanding physician, scientist, infectious diseases, former president of the association. Major contributions include a strong commitment to translational research, global health, development of academic physicians. So what's nice is it's all the things that we're still doing in the annual meetings. So that's tremendous, and that's both in the UK and internationally. The lecture was established in recognition of his major impact on medicine and enduring support for the association's mission. So it feels very fitting. What's also very fitting is today's lecturer for the next session, and that is Professor Sir Mark Caulfield, who doesn't really need much introduction to any of us, but just by way of brief introduction, Mark is Professor of Clinical Pharmacology at the William Harvey Research Institute at Queen Mary's. He's Vice Principal for Health, Warden of Barts and the London School of Medicine and Dentistry. And of course, possibly the role in which we really know him best is as Chief Scientist for Genomics England, and the architect, pivotal player, and the person delivering the 100,000 Genomes project. So Mark, it goes without saying, is internationally recognized in genomic medicine, cardiovascular science, precision therapeutics, and I would have to then echo, before I get told off, the importance of diagnostics to go with those precision therapeutics for anyone who was in the session before. His work has transformed our understanding of the genetic basis of disease, accelerated the integration of genomics into NHS care. He was knighted in 2019 for that service for genomic medicine, and continues to shape the future of how we develop this area of endeavour. And I think as we look at the NHS 10-year plan, as we look at the rollout of genomics, whole genome sequencing, the aspiration for how we apply this for newborn children, and then beyond, and how we take this into prevention, I think we can safely say, Mark, that everything you've pioneered to date is being acted on and is only going to get more and more important. So, Mark, thank you very much for coming. Thank you very much for giving the lecture. If we could invite you to take the stage.
Well, thank you, Neil, for a very kind introduction. And Liz, thank you for inviting me back. We probably shouldn't wait 15 or 20 years before we meet up next, because I mightn't be around. So, but this is a chance to celebrate a towering giant in medicine, and he was a towering giant, but he was very influential and a huge champion and influence on young clinician scientists, and encouraged them that the bridge was not too far to cross, and that you could succeed in academic life in this country. And again, we find ourselves, Neil, at a point of challenge to that clinical academic fraternity, or I shouldn't say fraternity, I should rather say that clinical academic community. And we've got to make sure as a team here in this association of all places that we do everything to maintain the front and centre and back of our clinical academic community. So I'm going to talk a bit about the 100,000 Genomes project and how we've used it to transform healthcare. But this is not something I should take credit for. There are many people in this room whose work I'll be talking about this afternoon. Here are some disclosures One of the things about working for the government for 8 years is you cannot really take any money from anyone else forever. So it's been completely unprofitable. But apart from I've enjoyed my normal salary and my career and the kindness and friendship of others here in this room. So this project, it's a London 2012 Olympic Legacy project. I don't know if you knew that, but it was incubated at the Olympic Park when the then Prime Minister David Cameron, we've been through quite a lot since him. Maybe we're about to go through another one, who knows. But he was inspired by meeting with scientists from this country, but also from around the world that were assembled at the Olympic Park, and they discussed this, and the conversation went sort of, well, this sounds really exciting. What if I did 1,000 genomes? And I said, no, we've already done that. What about 10,000 genomes? They said, no, we're doing that right now. What about 100,000 genomes? And that's where the 100,000 genomes comes from. So when I was asked by Sally Davis to become chief scientist, she said, look, this will just take you about a day a week. It won't be too much effort. 8 years later, and I don't know how many hours a week, we got through it and out the other side. But the important thing about this project was it was an opportunity to do something differently. And what I learned most importantly from it was, first of all, I think I was selected because I had no vested interest in rare disease, cancer, or infection, because I was a cardiovascular genomic clinical pharmacologist, not at all related to it. But what was very important was I spent a lot of time listening to the community, and then we therefore co-crafted this. It wasn't me, it was all of you, and as a result, we managed to get something that the NHS adopted within 5 years. So the 100,000 Genomes project was about whole genome sequencing. That's as much as you and I can read of the 3.3 billion letters that make you you, but can also carry susceptibility to disease. And the project was focused, before I started, on rare disease, cancer, and infection. And the reason for that was very reasonable. These were areas where genomics have been shown to be tractable to potential health gain, either through diagnosis or potential to have a precision healthcare solution for a disease, or to define bacterial resistance. So these were reasonable choices. I was presented with 4 letters. There were about 3 sides of A4. In essence, they all said more or less the same thing. This is really hard. Nobody's ever done it. We're not sure how to do it, but here are some things you could think of. Good luck. And that's what they did. There was never a grant written about this before it started. It was simply a cabinet decision to allocate the money to do this. And so we reached about 97,000 people during the project. We uplifted diagnosis in rare disease to 20 to 25%. I'll show you some of that data. And also about 25% of our findings, particularly, and this is why this is such a great place to be, Neil, for this talk, is particularly in Birmingham, because Birmingham was the largest cancer recruiter by a long way to this program. Thanks very much to Dion Morton and the cancer team here, who extended this across 17 hospitals. Participants were heavily involved from the outset. And if I learnt anything from this, Neil, it would be that what we should all do is get the participants in at the outset before we've decided what we're going to do, and help them shape it with us. Because that meant that there was a group of about 30 people who were stakeholders. They were either parents or people with lived experience of the disease who helped us shape the project. But when we ran into difficulty, they would also sometimes go into Facebook chat rooms, which I banned our team from going into, which was where the participants were discussing how we were doing and what we weren't doing. And sometimes those rooms were quite depressing for the team to hear about what was being said in there. But actually the participants became ambassadors and defended it. And I remember one participant facing down a Sun journalist who said to him, "Aren't you really worried they're going to have all your health data and your genome?" And the man said, "Look, I've been really ill for 45 years. I've had 2 renal transplants for my rare disease. I've given it to my daughter. Why on earth would I be worried about sharing my data if that could help other people?" The Sun journalist, this was in Newcastle, disappeared shortly afterwards. But what then happened was that we were able to engage about half of the English NHS And I was very grateful to Sir John Saville, who I went to say, look, this is really divisive. This project's funded by the NHR, and so Sally's given me instruction, you're not to spend any of my money in Scotland, Northern Ireland or Wales. So what we set about doing was we created corridors where people receive care in England, and so anyone receiving care in England in any devolved nation could come to the thing. I said it's not good enough. We've got to do something in each country, and each country set their own agenda for the project, and that work has continued in some degree. Some are more advanced than others. We reached about 98 NHS trusts, about half the English NHS, and at the peak there were 5,000 frontline staff who worked on this project at some point in the week. And the real virtue of asking the NHS to do this and not creating a giant parallel research team in Genomics England was that at the end of the project they said, look, we don't want this to stop. How do we make this into a national service? So it was much easier than the typical, we heard about it this morning in the cancer trials talk, the typical 9 to 16 years it takes for us to publish a clinical trial and then to decide actually it was really a good result and we should actually use these medicines or this intervention. So we also knew that we didn't have a monopoly of good ideas on what to do with this data, and so we encouraged researchers from around the world to join us and access the data for free, providing they were at a bona fide either hospital or university or institute, and about 3,000 from about 33 countries volunteered. And today those people have access to 140,000 genomes on over 90,000 people and billions of clinical data points. So I'll start with rare disease, and some of you will have seen some of these cases I'm going to show, but they actually create a story and a narrative which made me think a lot about this. So I had no experience of rare disease when I started this, and there were very kind people, some of whom are sitting here in the audience, who helped me to understand it. It was also difficult for the community to see a rather large project parachuted in that was quite disruptive to their own things, but people embraced it quickly and iterated it and helped us to shape it. And so what the situation we saw at the start was there were about 6% of the UK population, roughly 3 million people living with rare disease. About half the children would die before their 5th birthday, and most would not get a genomic diagnosis. And if you looked at the distribution of testing, you could get brilliant testing, Neil, here at Birmingham Women's and Children. But if I went a few miles down the road, it was quite different. And that's just the postcode lottery that's unacceptable. And so the result of this had to be an inclusive project. So we standardized eligibility, clinical characterization, and we used terminology that was, or ontology that was in use then, it still is, human phenotyping ontology. And that means our data here in the UK, when we very few families with a disease and can't get line of sight on a diagnosis, we can exchange data in a de-identified manner with other jurisdictions where they may have more cases, and that improves, the more cases you have, improves line of sight on a diagnosis. We automated analysis and we involved the NHS in confirmation both of the diagnosis and the decision to return to patients. It was very important that the NHS owned the project end to end and not parts of it, so it looked tokenistic, because these people were going to be needed if this was ever going to be in the NHS. So this is the first child here you see to receive a diagnosis. She was age 4 then. She's now about 18, 19. And she had presented with falling behind her milestones initially, and then intellectual deterioration. She was just not able to think things through, and then she started to get seizures. In the time we'll spend here this afternoon, Neil, she would have had several seizures in this afternoon. And so we analysed her genome and that of her parents. If you include the parents and the offspring, it improves your line of sight on a diagnosis quite considerably, because you can use the parents' data to filter out things that are not relevant to the diagnosis. So this little girl had a glucose transporter mutation in the glucose transporter that takes your glucose from your bloodstream into your brain. So she couldn't get her sugar into her brain. this was is otherwise known as an epileptic encephalopathy due to a metabolic problem. And the reason I'm mentioning this girl particularly is because it allows me to show you the journey of her genome. So her 3.3 billion letters had 6.4 million variants, 677,000 were rare, 2,826 were changing a protein, and 67 were different from her mum and dad. And one turned out to be in glucose transporter 1, which was the clear cause. But the other message from this is that her mum and dad had not transmitted that mutation. This was a de novo mutation that had occurred, as many of us get, almost all of us here will have some, that occurs at conception. And so her parents were never going to have children, but they've gone on since to attempt to have children. Now, I don't know the outcome of that. But for this girl, this made a difference because she can be treated with a high-fat diet. And what a high-fat diet allows you to do is to use the fat in the brain as a starvation prevention mechanism to convert fat to sugar. It's often known as a ketotic diet. So this young girl was the first to receive a diagnosis, but we then went on and analysed a pilot of 2,183 families where we'd achieved approximately a 25% diagnostic yield. The more family members you had, roughly speaking, the better your line of sight on diagnosis. And if you added research in, and this still is true today, 38% would achieve a diagnosis. If you just did it without research, you'd be at about 25%. And for certain disorders, some of the heterogeneous disorders, so we've done some work recently on the hereditary spastic paraparesis children in the 100,000 and the ones that have come through from the GMS. This is a highly heterogeneous disease with many different presentations and several different genes involved. And what you see is about a 12 to 15% diagnostic yield from the routine analytic pipeline in the NHS. But if you then apply this community in research endeavour, you add another 15 or 20% diagnostic yield. So that ecosystem, which we tested in the projects, turned out to be important. And then I'll go to the value of a whole genome. So the whole genome adds the value of all the things that you don't discover with other tests. And those are in the yellow, green, and orange there. And so you can see the added value of a whole genome. It gives a much smoother picture of the genetic architecture of your blueprint. So it's very valuable. So a couple of cases I want to use to illustrate something that triggered a thought that later led to the Generation study. This is a 10-year-old girl who was admitted multiple times to ITU. On the occasion where she was enrolled in the project was life-threatening chickenpox. She'd had lots of severe, unusual affections. No immune testing had shown anything. And she had mutations in the CTP synthase 1 gene. This affects B, T lymphocyte function, which means she struggled to fight bacterial and viral infection. So she'd really been very lucky to survive many visits to ITU. She got a curative bone marrow transplant, but if I tell you that the bone marrow transplant's not at all inexpensive, it costs £70,000, but actually her cost of care over 10 years with multiple ITU admissions was £356,000. A genome, when we started, well, the genome cost was about £850. And that was because we used the scale of the project to negotiate a very good discount. But if I put it to you that actually getting that diagnosis much earlier in her life would have avoided these life-threatening risks, but also is actually pretty cost-effective relative to what we've spent. But because we don't measure that so well over a longitudinal life course, we're not seeing the true cost of managing these diseases. And that is true recurrently in rare disease. The second case is a lad with a 4-year-old with anemia, developmental delay, and short stature. And he had a diagnosis clinically of diamond black fan anemia, which can be a nasty disease ending in cancer. His own sequencing found that actually he had a mutation in his thyroid hormone receptor alpha component, which meant he was insensitive to thyroxine. So he now goes to a metabolic unit every 6 or 8 weeks, and his thyroxine levels or dose are titrated to his metabolism, and he receives much bigger doses than you and I could take, but that's because you can get some of the effect through if you do that. So to keep him well, it's titrated. And he's shown great improvements. You can see a video of him. He's called Owen. His mum and dad want you to know who he is. You can see a video of him when we first saw him, where he's unable to walk unaided without his parents. And at the end, you'll see he can dance. Although his voice still remains very, very difficult to understand, he has improved quite dramatically. And he's led to multiple other diagnoses too. So we published in New England Journal in 2021 this analysis of the first 2,000 families, and it showed about a 25% diagnostic yield. But some disorders do much better. Eye diseases, certain neurological disorders, intellectual disability, hearing loss, and one or two others do very, very well. Where there are still some, which you can see there, that are a work in progress. They're waiting for all of you to turn up if you're interested in this type of thing and help get answers for these people, because they haven't got them yet. So we looked at the type of testing they'd had, if they'd had any testing, and compared it to whole genomes. And we looked at within patients. So basically the diagnostic yield with a whole genome, whatever way you looked at it, if they'd had no testing or some testing before, it was about the same, about a third. But if you had prior testing, you can see that some of the other tests, there weren't enough people with exome sequencing to really make a judgment, so I wouldn't rely too heavily on that. But essentially, a whole genome does improve your diagnostic yield. This is work done by Ariana Tucci, who works with me. She's a former MLC clinician scientist, and she used a program called Expansion Hunter that isn't meant to work on short-read genomes, and she analysed all the genomes in the 100,000 Genomes project. And this program, Expansion Hunter, was able to measure the repetitive sequences of your and my DNA and show a normal distribution, and then to show the disease threshold, and then to show the people who were undiagnosed with repeat expansion disorders. I'd like you to focus on the bottom row. So the triangles in red to the right of the serrated vertical line, they're affected people. The bottom line is Huntington's disease. The young lad who's on the far right at about 100, that was a child under the age of 10 who had had a massive repeat expansion. His father didn't have any symptoms of Huntington's. He'd been enrolled with undiagnosed hereditary ataxia. All sorts of features are not typical for Huntington's, and clinicians didn't know what the clinical diagnosis was. So this process found that repeat, and his dad is right next to the serrated line. So his dad, about a year or two after we made this diagnosis, began to demonstrate repeat expansion disorder in Huntington's. So she's gone on now to look across UK Biobank, and she's now working on all of us. And it turns out this is one of the most, repeat expansions are one of the most common causes for heritable neurologic rare disease. It turns out there are a lot more potentially pathogenic repeats. So this may explain some of the undiagnosed neurologic disease, because typically these disorders cause some form of neurologic disease. It's not only neurologic disease, they can be associated with other things too. So what was the diagnostic odyssey of children in this pilot data? Well, those families spent 6 years not getting an answer. They spent 68 hospital appointments prior to diagnosis, and their unaffected relatives in the same family around the same age spent about 18 appointments over 120 months, so over a longer period of time. Once you get a diagnosis, the clinicians immediately focus in, as you would expect, and therefore there's a far less testing being done because you've got an answer for why the person's like they are. And they used, over a few years, 183,000 episodes of care. If you chart these things using hospital episode statistics, these poor people, they're in and out of the service all the time. And that means that it's very, very demanding on the service. But it's like a military operation for these people and their families to get their kids or their young loved ones to the services. And we need to think about how we deliver these services. And we're moving towards multidisciplinary clinics. So, you know, I could see the child was in the renal clinic on Monday, then they were in the eye clinic on Thursday. Why not put them in the same clinic together? So we need to think about how we deliver these services, and that is being thought about across the genomic medicine service. But the cost is £87 million of these children not to get an answer. That's £15,000 per child. So Genome made £15,000. it sort of seems to work out that this could be affordable. And this is, it's not that their siblings don't use their system, it's that they use it less. So that doesn't include some of the visits to the health system, but that's the diagnostic odyssey. We move to cancer briefly, Neil, and we're 17,339 cancer participants. And it was the data from Birmingham that allowed us to show, because of the forensic way the Birmingham team had followed up across 17 hospitals, that there was about a 25% influence on cancer care. And if I show you that, it will be that some people got data that allowed us to avoid a drug because they had a pharmacogenetic predisposition to harm, that's DPYD. A number were referred to clinical genetics because they clearly had a unexpected hereditary cause, and the rest of the family could be screened. The majority got into a clinical trial, which I was very heartened by, and is very relevant to the talk this morning about clinical trials. But this is to show you an individual family. The woman in the green circle there had breast cancer, no family history of breast cancer, but we found a BRCA2 mutation both in her tumour and in her germline. And so she got to go in the Olympia trial, which was running then, of a PARP inhibitor, which actually turned out to be quite good for these particular variants and the tumours associated. Her daughter also went on to BRCA testing and was positive, and her daughter decided to have chemo prevention and also annual MRIs, but was thinking about a possible breast reduction surgery. And it's also relevant, has been recently again reiterated in publications, for the men in the family, because BRCA2 can be associated with prostate cancer. Sorry about this, I don't know what's happening there. Sorry about that. I thought I'd turned my phone off, but obviously not. So here's our analysis from 2024 in Nature Medicine on the 13,380 people with solid tumours. What we were able to do is to define molecular signatures in ovarian high-grade serous cancer and in glioma that meant that these were listed to go into the National Genomic Test Directory and have now done so. And that's in addition to hematological malignancies, which is actually challenging for whole genome because you need rapid hematological testing to turn around and get the patient treated because of the doubling time of the cancer. But also we have we have sarcoma, and we also have childhood tumours. What was also interesting, and I'll turn to that now, is that we could recapitulate already known mutational architecture and the outcomes from those. So you can see here common known cancer mutations that had already been defined in the literature. If I were to overlay those mutations with the clinical trials that they participated in, the Kaplan-Meier curves from real-world data, that's HES data, routinely collected NHS cancer registry test data, and our ONS mortality data, it recapitulates entirely the clinical trial findings of those mutations in other settings. So this raises a question to me, Neil, is what if we all longitudinally life course followed our patients that go into cancer trials, that go into other trials where they have long-term multi-morbidity conditions, and we use electronic health data to follow them against multi-omic tests that we might be doing. And actually that could allow us to detect long latency signals of benefit and long latency signals of harm. Because to be honest, most of our trials are too short to detect those. And also you need to deploy drugs at scale. But if we did this nationally, that would be an amazing thing, because some of the long latency adverse reactions take time to manifest. So moving on to that, we also looked at pharmacogenomics. And it turns out, in rather bad news for us all here, 99.5% of us have at least one gene-drug pair, which if we come across the medicine, it either won't work for us or it could harm us. And 25.4% of us here have at least 4 of those. We've been working with the yellow card system, and so what we did was to propose to MHRA that they created a yellow card biobank and that we deploy multi-omic testing for everyone with severe adverse reactions, because quite often we don't really understand why they're having reactions. So one that's topical at the moment is the GLP-1s and pancreatitis. So we're actually doing a study on that right now. We've also scraped the yellow card data back to 1963. We did this in 24. This is Emma McGavran's work. And the 1.3 million yellow cards which were associated with 115,000 adverse reactions that could be due, because we know how those drugs are handled in the body, to a pharmacogenomic interaction. And the majority of those were due to medicines that interact with only 3 gene-drug pairs, and that's cytochrome P450 type 2C19, 2D6, and SLC01B1. And 47% were mitigatable if we had known what they were for psychiatric medications. And if we'd known what they were for cardiovascular, there would be 24% that were mitigatable. A panel of 3 pharmacogenes would cover 80% of the known reactions. And that's obviously in the NHS 10-year plan and is being looked at by NHS England and Genomics England. So what do we do with all of this? Well, thanks to you and NHS teams across our country, at the end of the project, we started work in 2018 before we'd sequenced the last genome on a new genomic medicine service. And that's Sue Hill, who co-created it with me and has led the service since I left. And the idea was that we would have standardized genomic testing for the whole of England, and that Scotland, Northern Ireland and Wales would follow suit. That sort of happened, but not quite yet fully. There's a national genomic test directory now, which is revised annually. I didn't think I'd get that through the commissioners. I don't think they really noticed it when I did it, but that means that the only way is up for genomic testing, and the only way is better and more use of more complex tests. It also paves the way, the last speaker, Alex, was talking about multi-omics. I think the future is multi-omic, but it paves the way for that to be done. So I think it's the only form of commissioning in the English NHS where there's an annual review of testing, because normally we ossify a service for 3 or 5 years. If you do that with genomics, you'll be out of date within 6 to 9 months, and it will be disastrous. And then what they did was to create the 7 genomic lab hubs, and Genomics England remained for a long time responsible for sequencing. There's now a more distributed sequencing model coming into play. And the 7 genomic medicine service alliances are the clinical teams in frontline care. So that's the integrated ecosystem. So in COVID, like many of us here, we pivoted, and Paul was involved in some of this, who spoke earlier, to look at genomic architecture of severe COVID-19 in ITU. And in our initial study, which we did whole genome sequencing, but that data became available late. This is Kenny Bailey's work from the genomic study published in Nature in 2020. And this showed that tyrosine kinase 9 was a potential gene causing severe COVID, and that's the target for baricitinib. And in addition, I'm not going to claim that baricitinib was slowly selected for the recovery trial based on these data, because it wasn't. There were lots of other good reasons for baricitinib to be considered for the recovery trial. But the genomic data helped nudge it over the edge. So Peter and Martin put it into the study, and what you're seeing is the Kaplan-Meier curve, a 13% reduction from the addition of that to tocilizumab and dexamethasone. So the answer is genomics in certain settings, not ubiquitously, but in certain settings, can help us choose treatments and also prevent the harm from treatments. We went on to study that with whole genomes in 7,491 people with severe COVID from ITUs across the United Kingdom, and then 48,000 controls, and we found 23 regions of your and my genetic code. Subsequently, there's been an international host genetic initiative, which we joined in because it's the only responsible thing to do, and they've discovered many more such loci. But it does show that the genomic architecture of infection may be important, and some of the studies that were done by Julian's here somewhere in Oxford were very elegant studies of multi-omic dissection of severe COVID in the ITU. So I do think this has a role, but also has a role in pathogen sequencing. I'm not talking about that because that's Sharon Peacock's work. But we did do a lot of TB sequencing, and there is a service, and I'm going to mention it because we're in Birmingham, here in Birmingham, of TB sequencing for diagnosis and resistance, which was started here in 2018. And that allows you to diagnose TB very quickly, but also in about 24 hours more at that time, you could profile the resistance. So which, you know, we used to grow things for 6 weeks on Lowenstein-Jensen slopes, if anyone remembers that. And now we can do it in a very short time. So around 2018, the CMO, Sally, said, listen, I'm not very happy with my Chief Medical Officer's report, Generation Genome. I'm not happy about the children's section. Can you take a look at it? Can you assemble a group? And I want you to look particularly at children in ITU and children in at the newborn phase, and see whether we should do a better job of testing, genomic testing. So this led, so I assembled a group, wide group, social scientists, participants, intensivists, others with genomic backgrounds, and some psychologists. And then we went to test the findings with the public and patients. So there was no way we could embark on the things we were about to suggest without knowing that there was acceptability by public and patients. So we did extensive testing in a suite of focus groups, and they said for both rapid genomes and for a newborn study, they would be supportive of that, providing it was a returning and a useful diagnosis for clinical care, and that it was equitably accessible across the country. Now, Sian Ellard, followed by Emma Bapel from Exeter, started and now lead the National Service for Rapid Genome Testing for Children in ITU, but it now goes up to age 25 since the pandemic. They're showing 41%, a little out of date, Neil. It's about 42 to 47% diagnostic yield. And the important thing is that when you get a diagnosis quickly for a child that's been admitted to ITU, it makes it much easier to reprofile the care pathway, because you've got a diagnosis, you can explain the biology, and the parents are much more accepting of a pathway, which may in some cases sadly be palliative. So that service is live. It started with exomes, it's now whole genomes. Then finally, the other thing we proposed was a newborn study, which is now called the Generation Study, which was started after I left Genomics England, but with the team, we wrote the blueprint for it. And we estimated that if you looked at newborns and you identified genomic findings that led to a treatment, you could possibly reduce harm or avoid harm altogether in about 1 in 190 live births. That's now started with a more restricted set of conditions, so 208 conditions. But again, what they did was very sensible. They used the community, our community, and they said, what do you think we should do here? So there's expert input to everything. This makes it much easier to accept the return of such a result, which might have a profound effect on a child and on a parent. So we also looked at what it costs us not to make these diagnoses in avoidable situations. And it turns out for some disorders, it's about £360,000 a year to 1.4 million, depending on how much services they're using and how intensive that is. And if you could avoid harm and avoid premature loss of life, you could gain, because they're children, between 16 and 40 extra quality adjusted life years. But of course, that wouldn't be the case for someone of my vintage, because I haven't got those number of years left. But for children, you can gain that. And based on that, the department and the consultation funded whole genome sequencing of 100,000 newborns. So here are the results. 65,000 have been enrolled so far, 44,000 are sequenced and somewhere in the system. A lot of the babies that are enrolled are still in utero, so that's why there's no sequencing result, because they haven't been born yet. The last enrollment's expected between November 26 and March 27. 152 results have been returned, but we've been very focused on false positives, so they have identified about 10% of the false positives, but there is confirmatory testing in the NHS. The genome is turned around in less than 2 weeks. There's recall for research, their longitudinal life course followed, and you can test for adult conditions, but you mustn't tell a child about adult conditions until they attain Gillick competence or above the age of 16, at which point you'd be reconsenting them anyway, because their parents consented for them to participate in this. But I want to focus on a couple of things that have been, they've identified one mutation in POMC which would lead to adrenal insufficiency due to lack of ACTH, and that child has been immediately treated and will have a different course. But one of those is a diagnosis which initially the clinical community didn't want in the list, and they didn't want it in the list because the treatments weren't available in the UK. So they didn't see it as a treatable disorder in our country, but the government announced the treatments, and they found 3 cases of spinal muscular atrophy. Now, if you know this disease, it's otherwise called floppy baby syndrome. So when the babies are floppy, they will probably not sit up, they will certainly not stand, and are almost impossible to walk. But if you get in before that, as they've done here with the gene therapy that replaces the defective gene, that you can alter the course of that, and that's what's happened here. So the final results will take some time to be generated, and obviously it will require follow-up to do, but it looks like there are some preliminary cost-effectiveness analysis being done. If you simulate in what it would cost to manage these diseases, this could be cost-effective, but we won't know till we finish the study and see what the diagnostic yield is. Preliminary information from participants, which it's been shared with me by David Bick, who runs this study in Genomics England, is that people are very positive about doing it, particularly if you ask them to do it in the antenatal phase. Once they've got an ostensibly healthy baby, they don't want to consent to this sort of thing because they can't see that there's a problem. And often there isn't for several weeks or months because you're relatively protected in the womb. So, Neil, we also consulted in 2019 with the public as to what they thought genomics could do for them. Amazingly, the majority thought pharmacogenomics would be very helpful. They also thought that knowing about conditions that they had, they were inevitably, as everybody is, interested in ancestry and other things that they could prevent. There is a public appetite for this. Every time we tested it 3 or 4 times. They were very positive and very enthusiastic about that. And that's with a generalizable set of the British community across all 4 nations. So this is a strategy which I never thought I'd see, and I certainly never thought I'd see the forward to the first 10-year plan that we had a few years ago, written by Amanda Pritchard, embracing genomics in the NHS. I didn't think I'd see that in my lifetime, but that's because of the hard work of this community and the championship that the NHS and our clinical academic community brought to bear to make this a reality. And so we are still the only health system routinely deploying universally available whole genome sequencing for certain conditions. So today in 26, we are still building, because it's not a done job, a National Genomic Medicine Service, which will offer consistent and equitable care, no more regional postcode lotteries for 56 million people. I think it's on a journey to get there. I'm not sure it's there quite yet, but a lot of people working very hard to make sure it is fully realized. It operates to standardized protocols and a standardized genomic consent. And if I tell you of the genomes, about 100,000 people have been enrolled from the Genomic Medicine Service. 96% of them consent for research. So those data will all become available for research. So this is where we need to think about going, in my view, which is to harness the NHS, to get the NHS to do the research for the NHS, by the NHS, and at the end be the champions for its adoption. If we do this with parallel research teams that sit at some distance, at the end it's too easy to say this is going to be too difficult to adopt, oh, you didn't do it with us, and therefore we take 9 to 16 years to bring things into care. It's got an annually reviewed national test directory. Don't tell anyone what I said earlier. Building a single UK knowledge base as a national genomic research library. And what we can see is that scale has allowed us to find niche. So we are finding things because we've got tens of cases in one place. And other countries are coming to it to try and solve their diagnostic conundrum. So it's de-identified with permission for academic access, NHS access, and industry access, but it's a reading library, not a lending library, okay? And that's the difference between us and Biobank. We started and we resolutely followed forward, and that was because our participants wanted to know where their data was at all time. And this data has a massive footprint, as you saw earlier, and so just shipping it around was not an option. And I feel very relieved sometime later, Neil, that we did that, because fingers crossed, so far nothing bad has happened. I don't rule it out. And I've always told the participants that we can't rule out that someone will do something nefarious. As a result of the work that's been done, the government awarded 65 million a year for 10 years to Genomics England to do several things. One is to conclude and generalise the newborn programme if it's successful, and for an adult cohort of 150,000, probably focused on pharmacogenomics, but they're also looking at multimorbidity too. And the NHS is tasked with bringing pharmacogenomics live. So the future, of course, is a global coalition of intellects are driving this into healthcare. But I would say the future is not simply genomic, it's multi-omic. We now have data that shows that if you measure low abundance proteins, you can enhance diagnostic yield. If you measure RNA, you can enhance diagnostic yield. So as Alex said at the end of her talk, we've got to get ready for a world in which the diagnosis will be multifaceted testing alongside multimodal data at scale. So these are the most important people and projects, definitely not me. It's the participants. And they want you to see them because they like you to come and work on their data, because some of them haven't yet got answers for why they're like they are. Many of you here have done that, and I'm really grateful to you because you helped to demonstrate that the NHS research ecosystem is a vital part of our success in clinical care in this country. Here are the people who did the rare disease pilot. I'm afraid there's going to be a few slides, sorry, but I didn't want to leave anyone out. And so this was in the New England Journal in 21. And then this is the work on the COVID with Kenny Bailey and others. And I'd like to thank you for having me here and affording me this very great honour. But it's been a great opportunity for me to say thank you to the many amongst you who stepped up when everyone thought I was a bit mad, and actually the whole project was lunacy. In fact, I'll tell you, Neil, now, that in 2013, one of my very good friends, Patrick Chinnery, phoned me up and he said, Mark, he said, I've got some news for you. Either this is going to go very, very well, and at the end of it, you might get a knighthood. But from where I'm sitting, it looks as if it's going to go horribly wrong. And really, I think you're just lucky that in 2013, we don't send people still to the Tower of London, and we've given up cutting off their heads. So on that cheery note, I'd like to thank you all for listening, and do get in touch if you want to know more.